All right. Following that, my task here is to talk about cervical non-union, pseudoarthrosis. No disclosures are relevant here, and I think fundamentally the question when you're looking at a patient in the clinic who has a non-union is it a problem or not? And if it's asymptomatic, is it associated with instrumentation failure or not? Is there neck pain? These are the key things that need to be going through your mind. If it's asymptomatic, for the most part, I think the general principle is leave it alone. Fusion takes time. One of the things that I think we all learned from the arthroplasty studies was, the fusion rates for ACDF are really high, but some of them didn't fuse till 2 or 3 years after surgery completely. So sometimes just waiting it out if they're asymptomatic is the right thing to do. You can always follow up with them if symptoms develop. But I do think it's important to inform patients that, your bone's not healing as fast as we thought it might. We need to keep an eye on it, and you need to come back for follow-up. Symptomatic is a different matter. If they have neck pain, it's not entirely always clear that it's coming from the non-union, and you need to do a little bit of work to try to establish whether that's the case or not. Flexion and extension radiographs can help you if there's movement at the area of non-union. That is more likely to be the cause of pain. But sometimes it's just not clear, and getting a radionucleotide study to help you with that is useful. The thing that I think is probably most important when you're thinking about cervical non-union is, what are the things that are modifiable when you have a patient before surgery? There are multiple risk factors associated with non-union: smoking, steroids, diabetes, obesity, malnutrition. You want to optimize these conditions as much as you can. And certainly things that are modifiable, smoking, for example, and probably most importantly, you want to have patients not smoking before anterior cervical spine surgery whenever possible. There are also surgical factors that are important to consider in terms of preventing non-union. We talked in the lab about end plate preparation. It's just super, super important to pay close attention to that. And, I think somebody said yesterday, it's just an ACDF is not the way to think about these cases. Every ACDF that you do, you want to just do it perfectly. You want to have the end plates prepared properly. You want to have all of the disc removed. You want to really meticulously remove the cartilaginous aspects of this and avoid thermal injury to the end plates. You also want to choose your graft appropriately. You want to have an even distribution of load. You want to have a lordotic disposition to the spine. You want to avoid excessive distraction. Fracture and subsidence can result from that. And check with a C-arm to make certain that the graft is exactly the way is placed exactly the way that you want it, and that you've got this immobilized properly. There's some biomechanical factors that you can't readily change. There's some work shown by multiple groups now that T1 slope is associated with cage non-union. This particular study in Ren et al. 2000 is a large number of patients, case control type of study, but still I think makes the point that when there's a greater T1 slope angle, there's a greater rate of non-union, particularly at that level. A lot of people are interested in osteobiologics to enhance the rate of fusion, and so I thought it's worth just taking a look at the AO guidelines on this. I think there's no real data, no really strong data that really guides us in this regard. So what the AO guidance is saying is that either structural iliac crest autograft or allograft or cage plus osteobiologic can all be used with similar outcomes in terms of arthrodesis. Cage, when you're using a cage with osteobiologic, the recommendation is to use osteobiologics other than BMP in common clinical situations. And for revision surgery, there's really just no clear recommendations that can be made, although that's important clinically. And people ask, what about collar immobilization and bone stimulators? So some bone stimulator data I think is worth just taking a look at. Kevin Foley and his group looked in 2008 with a randomized controlled study, 323 patients and looked at stimulation versus no stimulation. At 6 months, they saw that there was a higher rate of fusion in the cervical spine. And at 1 year, there was also a higher rate of fusion, but it was not clinically significantly different from what was seen without stimulation. Mackenzie, a few years earlier, had a case report, and normally we wouldn't talk about a case report, but this was sort of interesting in terms of the imaging. They had lucency of the screws in a patient with a C6, C7 non-union, was treated with stimulation after that was found, and saw that lucency of the C7 screws improved, and the patient appears to have fused. That's in contrast with this randomized study, which looked at the get-go, at starting stimulation right after surgery. So it wasn't waiting until there was a sign of non-union. So just keep that in mind. In general, when there's a patient with an anterior cervical non-union that is symptomatic and is causing problems, and you're taking them back to surgery, in general, do it posteriorly. But also just something to keep in mind, this is the case that I saw that was done at an outside hospital, 2-level ACD&F with non-union at both levels. And if you look at the image down below with a broken screw at the top, who is referred in for addressing this pseudoarthrosis at both levels. And the bottom line was the patient had C7 radiculopathy, and if you look at his CT image, had a foraminal stenosis at that level, had no neck pain and right triceps weakness, and we did a foraminotomy for that, and his symptoms resolved. So even though you see it, and I think that's kind of the way I started this, it's not necessarily the cause of the patient's symptoms, and if it's not the cause of the patient's symptoms, you don't need to do anything about it by and large. And then last, just to leave you with this image, this is a lady that I did in 2013 who had a non-union at C3 and C4, no pain, just seen on radiographic imaging, and then you look at her 10 years later, and she's actually filling in a little bit around the screws, and again remains asymptomatic. So that's the key message that I would put forward for cervical non-union. Try to do the best that you can at surgery to prevent it. If you see it and it's not causing symptoms, just follow it. But sometimes they do need to be revised if they're truly causing symptoms. So thanks.
Yeah. In orthopedics at least, there's some newer data of people treating like tibial plafond, long bone fractures, like femoral shaft fractures, like tear peritide, and seeing like the rate units will heal. Do you guys have any experience using like tear peritide, like the cervical spine, for patients 9 to 10 months out? You don't want to rush to go back to revise.
So that's an intriguing idea. I did not know that, and I don't know if anybody has any experience with it.
I've used Forteo once for an odontoid non-union in an older guy who I didn't want to he actually had, I operated on him for myelopathy in the subaxial spine, and he fell years later, had an odontoid fracture, and I had heard Forteo was a magic medicine, and I had him on it for 6 months, and that odontoid union went from a non-displaced odontoid non-union to a displaced odontoid union with progressive myelopathy. That's my N of 1.
I've done it a few times for people with osteoporotic fractures where they've had severe back pain, and I don't love kyphoplasty because I think it increases the next level fractures. So we braced them and started them on teriparatide, and their pain got better, and that may have just been time. But actually, the fractures seem to consolidate, and sometimes I think those fractures, the osteoporotic fractures, they develop essentially a non-union within doing that. And in that subgroup, where it's easier to get it prescribed, is something that's been done. But I have no experience just using it for a cervical or lumbar non-union. But I have used it 6 or 8 or 10 times in osteoporotic fractures because you're treating them because they've got
osteoporosis. Yeah.
So it makes it easier.
I mean, it improves fusion in lumbar fusion. teriparatide is pretty well known to show increased fusion for lumbar intertransit process fusions. I can't imagine it wouldn't work for them, but look from the back. Yeah, I think it increases initial fusion, but not all.
Ask about collars, because you talked about collars.
Yeah.
I put all my 2 levels in a hard collar. I have no idea why.
Yeah, I don't put anybody in. I don't put anybody in a collar anymore, and I haven't put patients with asymptomatic non-union in a collar either. So I don't know.
Ricky asked earlier, it just popped in my head, you're an external bone stimulator guy, so so the reason why is, I remember you told me, and I used a couple people with acute pars fractures in young kids. I put them in an external bone stimulator, which caused that to go on to fuse. You told me that, and I've used that in a few cases. What's your belief of salvaging non-unions with external bone stimulators?
I don't think it works. Actually, I was part of that ID trial that you quoted Foley. Foley was a PI in that, and just as you said, but this is a little different. This is, and they were high risk ACDFs patients. We only looked for smokers. That's why we only did it in Tennessee and Indiana. We looked for smokers who had a high risk of non-union, but all of them got an external bone growth stimulator in their collar, or just a collar with a fake one, and it seemed to show that the fusion rate was quicker. So at 6 months there was a statistical difference, but at 1 year all that difference washed out, and it was not statistically different. So I don't use bone growth stimulators for any of my cervical patients. Only my young teenagers with spondylolysis at L5.
It does work. It works
It does.
in my N of 1, but you told me to do that.
I did.
Maybe I've done an N of 2, but you remember you telling me that at some conference telling me to do that.
I found it's really hard to get the payers to pay for these external bone stimulators also. So I don't use them either.